afternoon, and good evening. My name is Sara Chamberlain. I'm the Digital Director for BBC Media Action in India. I spent the last 11 years working in India and am honored to have this opportunity to present some of our learnings to you all in today's digital health lecture. Next slide, please. BBC Media Action is the BBC's international charity. We believe in media and communications for good. Last year, we reached more than 130 million people in some of the world's poorest and most fragile countries. Our projects and programs save lives, protect livelihoods, counter misinformation, challenge prejudice, and build democracy. I'm joined today by Dr. Amnesty LeFevre from the University of Cape Town, who has led several of the world's largest evaluations of digital health programs. I would also like to note the contribution of Dr. Claudia Lopes at the UNU IIGH's Gender and Health Hub. Next slide. Today, Amnesty and I are going to discuss the gender intentional design of digital health solutions. We'll tell you what it is, why it matters, give you some examples of how BBC Media Action has applied gender intentional design methodologies in India, and some suggestions for how you could do it yourself. Next slide, please. Our learning objectives for today's lecture are that you will have a greater knowledge of gender intentional design, a deeper understanding of why it's more likely to result in inclusive digital health solutions, and feel more confident about using gender intentional design methodologies. Next slide. I'm sure many of you are familiar with the gender digital divide, which the US State Department defines as women and girls' lack of access to, use, and development of information communications technology. Digital technologies have helped some women in low and middle income countries gain employment, increase their incomes, and access cost-effective healthcare and education services. During the COVID-19 pandemic, as digitization accelerated in 2020 and mobile technologies and services generated 4.4 trillion of economic value, some women use mobile phones to access COVID-19 information, to stay connected to their families during lockdowns, continue their business activities where possible, and access support from the government and other institutions. However, the transformative potential of digital technologies has been constrained by the gender digital divide, which has emerged as a profound barrier to social and economic inclusion, including limiting the reach and impact of digital solutions to support vaccine demand generation and delivery. So what does it mean to be digitally literate? Historically, digital literacy definitions have focused on skill, i.e. someone can use a specific tool such as Microsoft Word on a computer or WhatsApp on a mobile device. But definitions have subsequently evolved to focus on how people are using digital technology. For example, the European Commission talks about confident, critical, and responsible use. Definitions also focus on what people are using digital technology for. For example, the Indian government talks about meaningful use in lives and in society. When designing digital solutions in contexts where there is a significant gender digital divide, for example, in South Asia and Sub-Saharan Africa, it's critical to adopt a gender intentional approach. What does this mean? Melinda Gates has defined gender intentionality as identifying and understanding gender inequalities, gender-based constraints, and inequitable norms and dynamics, and taking steps to address them. Next slide. So how do we apply gender intentionality to the design of digital solutions? Next slide. The gender intentional design of digital health solutions is rooted in a gender and equity analysis of who has access to digital technologies and why, and who is excluded and why. The figure on this slide, which is from a seminal article by A. Pedersen et al., depicts a gender continuum framework. On the far left-hand side of the continuum are those health programs which are gender unequal, and as a result, exploitative due to their role in perpetuating and or reinforcing existing gender inequalities and norms. Digital health programs which ignore gender norms and needs, including the gender digital divide, are gender blind, i.e. accommodating and working around gender differences and inequalities. Digital health programs which acknowledge but stop short of addressing gender inequalities are gender sensitive, while those that endeavor to address them are gender specific. On the far end of the continuum are gender transformative programs which address the causes of gender-based health inequalities and work to develop specific strategies to transform gender gaps in digital access, ownership, and use, and in turn, the differential impact programs may have on developmental and health outcomes. To quote UNICEF's excellent summary, a gender transformative approach therefore attempts to promote gender inequality by fostering critical examination of inequalities and gender roles, norms, and dynamics, by recognizing and strengthening positive norms that support equality and an enabling environment, by promoting the relative position of women, girls, and marginalized groups, and transforming the underlying social structures, policies, and broadly held social norms that perpetuate and legitimize gender inequalities. Next slide. So why does gender intentional design matter? Next slide. To quote Melinda Gates again, development projects that ignore gender inequalities usually fail to meet their objectives. USAID concurs that programs that incorrectly make assumptions that their users or beneficiaries have the required digital skills may set themselves up to fail or deepen the divide between the digital haves and have-nots. For example, many governments' COVID-19 contact tracing programs made it mandatory for citizens to download and install apps on smartphones. Some countries fine citizens who did not have the app on their handset. Unfortunately, in countries where a large gender digital divide exists, this penalized up to 75% of the female population who don't own smartphones. UNU IIGH's Gender and Health Hub highlighted these concerns early on in the pandemic, writing that failure to address the known and emerging gender-related inequities during the largest global vaccine deployment in history will delay vaccination coverage, add to the COVID-19 morbidity and mortality, and to its burden on the health system. Next slide. So what is the scale of the gender digital divide in your country? It's worth looking at the GSMA's annual mobile gender gap report for trends. According to the 2022 report, 40% of women across low and middle income countries were still not using the mobile internet in 2021, and women's uptake of the mobile internet in these countries has unfortunately stalled. Among low-income groups, there is evidence that the economic impact of COVID-19 has made handsets and mobile internet even less affordable and affected access to smartphones and mobile internet use. In South Asia, for example, the mobile internet gap narrowed significantly from 67% in 2017 to 36% in 2020. But unfortunately, it has now widened again to 41%. The GSMA report includes a deep dive into two countries, Nigeria and India, and I'm sharing some of the statistics for India on this slide. In particular, it's noteworthy that although India now has one of the largest social media markets in the world, only an estimated 30% of its users are women, representing approximately 10% of the female adult population only. This data comes from a report by We Are Social and Hootsuite, which tracks advertising reach on social media platforms globally. You can find out more about the gender divide on social media in BBC Media Action's report, Why Aren't Women Part of the Conversation? A study of the gender gap in social media use in India, its causes, and the implications for women's empowerment. The link is on this slide. So what factors determine whether a woman owns and is able to use a mobile device? I'm going to hand over to Amnesty now to provide some insights.
Thank you so much, Sarah. So this slide depicts a conceptual framework that was developed by our colleague, Dr. Carrie Scott, and recently published in a special supplement in BMJ Global Health. The special supplement, we have a link at the end of the presentation, and a link to the specific article is on the bottom of the screen, but we encourage you to go there. So while this work emanated from our team's work in the central Indian state of Madhya Pradesh in India, and focuses on determinants of phone access and use, I think it has broader applicability to other ICTs and geographies. So let's take a moment and just go through it very quickly. If we focus first on the circle on the far right of the screen, we see 5 immediate determinants of women's phone access and use: access to the handset, the phone's characteristics and functionality, women's digital skills, permitted and desired use, and time allocation. A woman may report that she has access to a phone, but is this access only when her husband is home? Is the handset she uses partially broken? Does she have the autonomy to go to the shop and the money to add credit? Is she able to read SMSs, to take a photo, to dial a number? What does she want to do on the phone, and what is she allowed to do? Might she get in trouble if she's seen using the phone too often? These determinants are embedded in a larger set of secondary components at the level of the woman, the household, and within the broader context. And they're all grounded in gender norms and overall social attitudes towards women's phone use. And again, for those more interested in having a deep dive into this, we encourage you to take a look at Carrie's broader paper. And otherwise, Sarah, I hand it back to you.
Thanks, Amnesty. As we just saw on the slide she presented, gender norms play a critical role in women's digital access and use. BBC Media Action conducted a landscaping study of all the major digital literacy interventions in India to understand which approaches have been successful and which have not. As you can see, you can see the link to our report on increasing women's digital literacy in India, what works, on the slide. We found that many interventions had failed to achieve their objectives because they ignored gender norms. Our landscaping study identified 6 normative barriers to women's digital literacy. First and foremost, the value proposition for women's ownership and use of mobile phones has yet to be established, particularly in rural areas. When designing inclusive digital health solutions, it's critical to try and answer this question. In other words, is your proposed solution relevant to women's lives, and will it fulfill a compelling need? Next slide, please. When designing inclusive digital solutions, it's also important to consider age. For example, as you can see on this slide, in 2021, only 3% of Meta, aka Facebook's, users who can be reached via advertising in India are women between the age of 35 and 44. And this percentage declines further for women and men above the age of 44. So if your objective is to increase vaccine take-up among women above the age of 35 in India, it might be worth considering running campaigns on alternative digital platforms and channels. Next slide, please. So I've talked a lot about challenges. Now I'm going to give you an example from BBC Media Action's work in India of how it is possible, using gender intentional design methodologies, to create inclusive digital health solutions that have a positive impact on the lives of low literate, low income women. Next slide. Our challenge was to promote healthy reproductive, maternal, neonatal, and child health practices and generate demand for public health services among millions of low literate pregnant women and new mothers and their families in India. Our approach was to use a gender intentional, human-centered design process to create Kilkari. Kilkari delivers stage-based, time-sensitive, pre-recorded audio information directly to families' phones every week for 72 weeks. It addresses both mothers and fathers and is integrated with national government databases that register and track pregnancies and births in India. Next slide. By the time we transitioned Kilkari to the Indian government in April 2019, it had 10 million subscribers in 13 states who had listened to 200 million minutes of health content. Kilkari is still going strong today and has apparently reached 28 million families. Between 2018 and 2021, Johns Hopkins, working with the University of Cape Town and others, conducted a randomized control trial of Kilkari in the state of Madhya Pradesh. The RCT found that exposure to Kilkari content on immunization was significantly associated with an increase in child vaccination at 10 weeks. Exposure to Kilkari content on family planning was significantly associated with the adoption of modern contraceptive methods, and the RCT concluded that Kilkari is a cost-effective approach to saving lives. Next slide, please. I'm going to move on to tell you a little bit about the gender intentional design methodologies we use to create Kilkari. But first, I thought I'd quickly share some of our key learnings from scaling and transitioning Kilkari and other digital health solutions to the Indian government. I don't have time to go into the details on this slide today, but you can read more about these valuable lessons in an article in the BMJ Global Health Special Supplement that Amnesty mentioned. The link is at the bottom of the slide. Next slide, please. So I'm sure you're all wondering at this point, how do you actually do gender intentional design? We're going to share an overview and some pointers now, but a quick disclaimer. Just as you can't learn to be an epidemiologist in 30 minutes, learning gender intentional design of digital health solutions also requires more intensive training. The UNU IIGH's Gender and Health Hub is leading a consortium of partners to create a MOOC on the gender intentional design of digital health solutions. So this is just a teaser, and please watch this space. Next slide. To summarize, gender intentional design is human-centered design with a gender lens. This figure on the slide depicts a 5-stage HCD process that was first pioneered by the design school at Stanford University. BBC Media Action adopted and adapted this process to create Kilkari in India. You can read about how we did this in another article published in the BMJ Global Special Supplement. The link is on this slide. But to summarize, the discovery phase involves formative research, but gender intentional formative research, i.e. the observation, engagement, and immersion to understand the target groups you aim to serve. The define stage involves the analysis of research results to define the problem and to develop theories of change that recognize gender inequalities to deliver equitable outcomes sustainably at scale. To generate ideas for how to solve these problems, a multidisciplinary project team, including stakeholders from the community, generates gender-sensitive or gender-transformative ideas, shortlisting those to take forward into the design process. And finally, prototypes are created and iteratively tested with different genders, age groups, and socioeconomic segments of the population to design effective and inclusive digital solutions. I'm now going to hand over to Amnesty to talk more about the research involved in not just digital intentional design, but also evaluation.
Thanks so much, Sarah. So in this slide, we've taken the same 5 steps that Sarah presented in the prior slide, and we've interfaced illustrative evaluation activities that you might consider doing, or I should rather say evidence gathering activities that you might consider doing at each step along this process. At the first discover step, we recommend first doing a landscape analysis, which gathers evidence on the target population and identifies key evidence gaps. This is followed by immersion trips, which include in-depth interviews and observations. Once these first steps are done and the target population has been identified, one might then proceed on to baseline surveys, which aim to gather evidence on knowledge, practices, information on phone access and use, and a variety of other factors. These are then followed by interviews with other key stakeholders. And finally, from there, we move on to the define stage, where we utilize the data gathered in the first step to identify inequalities in access to healthcare and mobile phones, identify barriers and triggers to behavior change, define digital archetypes, including the types and conditions of mobile phones available to your target population and their available digital skills. And then we use mixed methods to assess health systems linkages and deficiencies, which may impact the effect of your digital health program and referral services. In a third step of generating ideas, we mine insights from the data gathered in the prior two steps to inform program and solution design, including theories of change, communication frameworks, business models, and implementation plans. In the fourth step of prototype, we've launched the solution, and here are establishing M&E systems, including attaining agreement on indicators, dashboards, and conducting a process evaluation to ensure that the intervention is being implemented as intended. Finally, this brings us to our final step of testing. And it's here we're really engaged in a range of activities, from pre-testing and task-based user testing, providing monitoring and implementation support, and conducting more robust impact and economic evaluations. What is not depicted in this framework is that many of these steps would need to be repeated as solutions progress along their stages of development, from prototype all the way up to scale and sustainability. However, to catalyze this evolution, robust data are needed throughout the process. And here, let me just take us to our next slide. I think a critical impediment to our ability to gather effective data is, one, agreement on metrics, which can be utilized to capture a lot of the evidence mentioned, and then having an adequate number of resources or amount of resources to support programs and the conduct of external evaluations. Sarah, back to you.
Thanks, Amnesty. And I realize at this point, I realize we've given you a lot of information. So the folks at the WHO and CDC asked us to summarize and provide you with 3 truths and 3 best practices for designing equitable, gender-specific digital strategies. So the first truth: we must proceed with caution when designing digital health solutions, because, as you may have gathered now from this lecture, it's very easy to make existing inequalities worse and to exclude already marginalized populations. Secondly, there is no one-size-fits-all solution. People have different levels of digital access and use depending on their gender, socioeconomic status, level of education, and age, and will require different solutions to meet their needs. Following on from this, we cannot ignore the large percentage of the population in South Asia and Sub-Saharan Africa, particularly, who do not own mobile phones and still require face-to-face demand generation and service delivery. Next slide, please. To ensure that you create impactful digital health solutions that meet your objectives, it's best to start with a gender analysis of who has access to which digital technologies and why, and who is excluded and why. Once you've done this, you'll have a much better sense of which technologies are appropriate for which segments of the population, and can begin designing appropriate digital solutions with your target users. For example, video content delivered via WhatsApp to women who own smartphones and know how to use them, versus pre-recorded audio calls made to women who can't read and write and only own feature phones. And lastly, don't forget to identify and engage the power brokers in the family and community, because they control access and monitor use. Next slide, please. So we're coming to the end of our lecture, but before we go, we're going to suggest some practical steps you can take depending on your operating environment. Next slide, please. If you have limited time and resources, identify available country-specific data that can help you to guesstimate women's level of digital access and skill based on wealth and education. Examples of data sources might be from the GSMA or DHIS or MIX. Also, identify existing communication channels, both digital and face-to-face, that you could piggyback on. Undertake rapid qualitative gender intentional design to create digital content with respondents from your target groups that can be made available to users via these channels, and assess reach and engagement using phone surveys and qualitative interviews. Please note that phone surveys have reliability limitations when it comes to measuring and attributing impact, and for that reason are contraindicated in some cases. Next slide, please. If you have mid-level time and resources, conduct a small primary research survey to measure digital access and use. And make sure you can disaggregate that data by gender, socioeconomic status, and education. Procure a digital vendor on a software as a service basis to quickly and easily launch solutions. Undertake iterative, qualitative, gender intentional design to create digital solutions with respondents from your target groups. Use system-generated data to monitor take-up and usage, and conduct an independent evaluation, which includes primary research and analysis of system-generated data. Next slide. If you have a higher level of resources and more time, conduct a large-scale primary research survey on digital access and use, and use machine learning to segment the target population and design for specific segments. Procure a direct-to-consumer digital communications platform to send the right message using the right channel to the right person at the right time. Integrate it with the government's databases that track the continuum of care, including vaccine delivery. Undertake iterative, qualitative, and quantitative gender intentional design to create digital solutions with respondents from your target groups. Use system-generated data and face-to-face research to monitor take-up and usage. Conduct a process evaluation, including to assess scalability and sustainability, and conduct a randomized control trial to evaluate impact and the cost-effectiveness of your intervention. Next slide, please. And before we go, here are some references for you to consider that might be of interest. And I hope you enjoyed our lecture, and we look forward to continuing the conversation. So thank you, and goodbye from me. Goodbye from Amnesty.
Thank you very much. Thank you, everybody.
And have a good rest of the lecture series.
Thank you.